Hi, my name is Jennifer Dorr. I'm a board-certified psychiatrist, and I'm in private practice. And I run a wellness center a little bit south of here in Woodside, California. And I've been treating patients with ketamine for about the last 4 to 5 years. And it's been an amazing journey immersing myself in psychedelic medicine because I've had the privilege of working with one of the only, but not for long, legal psychedelic medicines in the context of my general psychiatry practice. So after a few years of treating patients in my private practice, many people got better, but there was lots of people who didn't. So I went on a search for new tools, not only for the people who didn't respond to standard treatment, but also for those patients who got stuck at a certain point. Those were the two kind of pain points. I practice intensive psychotherapy, psychopharmacology, and when I went on the quest for looking for new tools, I found Dr. Phil Wolfson, who became my mentor and my colleague in developing, understanding how ketamine fits in with psychotherapy and how it can be helpful for patients with a whole range of diagnoses. And we've been trying to spread the awareness of ketamine-assisted psychotherapy since then. And part of the reason I was invited here, part of it is because Dr. Wolfson is in Europe right now, but also I'm one of the authors of the paper that we wrote in the journal Psychoactives on ketamine-assisted psychotherapy, which looks at 235 patients treated with ketamine-assisted psychotherapy over many years since it's been used. So I come to this from a unique standpoint because I trained in general surgery and then I trained in psychiatry at Stanford. And so I have this appreciation of the power of intervention and the quality, the intensity. And when I started to use ketamine, it really worked. And it worked better than anything else that I'd ever used. And it was rapid. And not only was it rapid, it opened up people to the concept of change and transformation. And so that may not be a new concept to people who have been using psychedelics, but certainly being trained in the last couple decades in medicine and psychiatry, this was really new and exciting. So this is a quote from one of my patients who sort of coming out of a ketamine-assisted psychotherapy session, and we were doing integration, and they said, no, the feeling, a lot of times it's really hard to describe what the feeling is like during ketamine-assisted psychotherapy or some of the visions or experiences. But this patient said, no need to hide, no need to be seen. And I really like this quote because I feel like it speaks to the power of ketamine to help people with shame, hiding, and also to help people with sort of obsessional thinking and narcissistic thought loops. So I really liked how succinctly this patient expressed it. So just a little snapshot about ketamine as a medicine. Ketamine is a dissociative anesthetic. It was discovered in the 60s in the quest for novel anesthetic agent. It was coined dissociative anesthetic by Edward Domino's wife, describing the experience during ketamine. And ketamine works through glutamate, which is a little bit different than some of the other psychedelic medicines that utilize the pathways of serotonin and dopamine. So this is one of the reasons why ketamine has been getting a lot of press in the field of psychiatry and depression, because it works on a different neurotransmitter system than most of our standard treatments. Ketamine also has a good safety profile. We know this through the pain management literature. It's been used for chronic pain decades before we started using it for treating depression, which is probably what you most are familiar with and is popular today. And it's rapidly acting and is shown to be effective for treatment-resistant depression as well as PTSD. And now every week there's a new paper on it. I have a Google setting on my email that gives me alerts about papers and case studies and different research with people looking at all different types of diagnoses and mechanisms of action for ketamine. So, but the interesting thing and relevant today is that ketamine-assisted psychotherapy and ketamine treatment actually has a lot of its roots in addiction treatment. Some of the earliest work in addiction treatment was done by Salvatore Roquet, who's sort of a controversial figure between 1964 and 74. Ketamine was used alongside other medicines to treat mental suffering as well as addiction. Then in the late 90s, we had some of the groundbreaking studies by Krupitsky, which showed that ketamine psychedelic therapy, which is basically the same thing as ketamine-assisted psychotherapy, that it prolongs abstinence from alcohol in detoxified alcoholics and abstinence from heroin in heroin-dependent individuals, and that's 97 and 2002, respectively. And interestingly, as I was preparing my talk for today, a couple days ago, there was a study showing that a single ketamine infusion along with mindfulness reduces the relapse in cocaine use disorder, and that was by Dakwar, who's been doing a lot of really interesting work on cocaine use disorder and ketamine. So Krupitsky actually put together the foundations of ketamine psychedelic therapy, which is really the core of ketamine-assisted psychotherapy or psychedelic psychotherapy in general, which he described it in 3 phases. One, there was a preparation session in which the patients who were addicted to alcohol discussed what things might come up. This is very similar to what we do in our practice. We prepare patients, we consent them, and we talk about what might be relevant to explore in the psychedelic state. So then there's the experimental session, which is after that. And Krupitsky used very high dose ketamine compared to what we use for depression today, about 2.5 milligrams per kilogram. And the patients were verbally guided by a therapist, and they focused on making new meaning. So here's this emergence of the mystical experience and how that is important, kind of playing on the history of this and the treatment of addiction and mental disorders and transformation in general. And then there was followed by a group therapy session which did a lot of the integration work. So this is the real model of what we do today: preparation, evaluation, experiential session, and integration. Just some more details on those studies. In 1997, the study with alcohol use disorder was 111 patients. They were inpatient, they were detoxed, and then you can see the abstinence rates were better for the ketamine group versus the control. But this wasn't a randomized or blinded study. And they didn't see any addiction to ketamine. And then here's just some more of the details of the heroin study in 2002. This was double-blinded, and you can see the high dose really won out over the low dose. And there's some controversy over whether the low dose or the high dose is better and for what patients. And in our clinical experience, that really varies based on what you're treating. But it seems that in the addiction literature, at least with Krupitsky, the higher dose was much more effective. So I think it's important to talk about, if we're going to understand how to use ketamine, and I'm going to sort of put it alongside all the other psychedelic medicines and evaluate its potential, which is really, really important for us to all do. And it's a real honor to be a part of this conversation. I think we need to know what the ketamine signature is. And ketamine, as I talk to all my patients, it has a biological effect, for sure. People are given ketamine in an IV. That's how many of you may have known that it's become popular to treat depression. And it works, but it doesn't always stick. And that's one of the big problems. If you don't use the psychotherapy, or at least we believe that using ketamine with the psychotherapy helps to prolong its effect and to really open patients up to transformation and long-term changes in the way they live and the way they think about themselves. So we have to understand what the signature is to really understand how to use it. Oops. So the way we use ketamine-assisted psychotherapy in our office, setting is very important. We use eye shades. We use comfortable couches or futons. We tuck patients in. We really try to care for them and focus on them. And they dissolve the medicine in our office in a setting like this. This was my old office. And this is really very similar to the protocols for MDMA-assisted psychotherapy. Although ketamine is a little bit more tailored to office-based use because of how long it lasts. Instead of 6 to 8 hours, the peak lasts about 40 minutes. 15 to 40 minutes, and the whole experience a few hours. So we do sessions that last about 2 to 3 hours. And as I was saying, ketamine's become popular administered in the intravenous route, which is 100% bioavailable, but this is mostly in a medical model. Some people provide psychotherapy along with the intravenous, and that would be considered as ketamine-assisted psychotherapy, but the majority of people who receive ketamine in the IV, they don't receive therapeutic support, and it's very clinical. And that really changes how it works, at least in our opinion. You can get the full range of dosing that you get with the IV with the use of sublingual lozenges, which you see here, as well as intramuscular injections. And these two routes of administration are really used mostly in the setting of psychotherapy, and that's how we use it, and that's how we use it in the paper that we published in the journal. So here's the signature. Ketamine's pretty amazing because it can produce a broad range of effects that are really different. So with the low-dose sublingual lozenges, you can also get this with the IM injection. The sublingual lozenges come on much slower and provide a little bit of a different experience from that perspective. But the low dose, whether IM or sublingual, can produce an empathogenic experience, similar to MDMA, but not as intense. Feelings of happiness, increased awareness of the body, empathy are really hallmarks of this particular state. Decreased obsessional thinking, radical presence and acceptance, decreased defenses. I explain to patients it really kind of puts that inner critic or that inner voice to the side, and then you get to experience whatever else is left. And that really varies from person to person. There's not really a very predictable, there are themes, but not really a very predictable course of what a particular patient will experience. Then as you go up in the dose range, you can experience out-of-body experience, 75 to 125 milligrams IM. Although you can experience this at the lower doses, every individual is sensitive in a different way, and we don't exactly know why that is, at least now. So the way that we do it in our practices and the way we did it in the paper is that we titrate to the experience that the patient is having. A few people will have out-of-body experiences at the low doses, and we don't know why, but in general, this is how it goes. So out-of-body experience, that can be very useful for patients. This detachment from the body where, a lot of us feel that trauma lives in the body, not necessarily in the mind. And exploration of vision, dreamlike realms. And at the higher dose, you have complete ego dissolution and a near-death experience, which can be really, really helpful. And this was the kind of experience that was seen to be helpful in the Krupitsky research. So this is, the way we describe it is we utilize the trance and transformation. You have this whole spectrum of effects that you can get from one medicine based on the dose. And in your practice, and you can imagine treating patients, that the different states are helpful for different patients, for different diagnoses. So what are the benefits from ketamine-assisted psychotherapy? So part of the reason that I'm talking to you about ketamine today is because the paper we published takes data from 3 distinct general private practices, 2 here in California, 1 in Texas. We looked at 235 patients, and this was the study that the data was collected prospectively and analyzed retrospectively, so it was an observational study. But most of the things that have been published on ketamine to date have been using the IV model, and so we really wanted to bring awareness to ketamine-assisted psychotherapy, how we do it and how it can be effective, or just as effective as the IV. And this was sponsored by the Ketamine Research Foundation. So this is the method that we used, which again is very similar. I started to describe it to MDMA-assisted psychotherapy: psychiatric evaluation, prep session, experiential session, integration. And then each of the courses of ketamine are tailored to the individual patient. So we start out with every other day ketamine for about 2 to 6 weeks, and really depending on what the patient's experience is and relief from symptoms, we put together a program that isn't just an algorithm, it's really based on the patient's response. So we use the first initial experiential session to figure out what the dose is to achieve either the trance or transformation, and that's different with every patient, but is in the range of 200 to 400 milligrams sublingual. And then we continue on from there. And that's the basic protocol. which is very individualized. So these are the diagnoses that we looked at, and you can see there's substance use disorders, or at least diagnosed substance use disorders that we had in our charts when we look back at them, and we grouped them together here. Adverse effects, ketamine can produce nausea, vomiting, agitation. These were pretty uncommon. So we do in-office sessions, but we also, under close monitoring, prescribe ketamine lozenges, like the ones you saw on the previous slide, to patients so they can take it home and use it. And this is in the context of close monitoring and psychotherapy. On one hand, there's an increased risk of diversion and abuse potential, but the benefit of that is that patients become very engaged. It's the difference between the model of the IV versus the ketamine-assisted psychotherapy. In ketamine-assisted psychotherapy, patients are really engaged. They're involved in their treatment. And then when they can take home the medicine and do some of the work at home and then integrate it with us, that's a tremendous benefit, because patients start to see, wow, I can be the source of my own healing, and I can be responsible. I can see myself in a different way. And this has really worked. We have not seen... We've had a few individual cases I've treated hundreds of people, Phil's treated hundreds of people, and across my colleagues, we really haven't seen the diversion with the lozenges or ketamine abuse. It does happen, and it may be underreported, but at least in the patients that we see weekly, twice weekly, twice a month, we don't see it. So the adverse effects acutely, nausea, vomiting, agitation, and then from the long term, we worry about inflammatory bladder conditions, and we worry about cognitive effects. But again, we really don't see that. That comes from the literature from addicts who have polysubstance abuse, as opposed to the people who have been treated for depression or PTSD. And so this was the real message from our paper, which was that we collected measures on our patients from when we started out, and sort of how Phil Wolfson taught me to do it and how we've taught everybody how to do it. And so we had a lot of data for people, and we looked at BDI, we looked at HAM-A, there were several other measures, but what came out of our data analysis was that we had a clinically significant decrease in the HAM-A and the BDI, and that was really great for us to be able to show that. So number of ketamine sessions correlated to improvement, and patients with really severe symptom burden really did much better, and that included improvement in drug and alcohol use scores with treatment. It's just something that I wanted to highlight. And older patients also did better. There's some reasons why we think. So how do we think ketamine works? Just a few more words. We think it really works on many different levels. Biologically, glutamate plays an important role in the changes that synapses undergo in response to experiences that underlie learning and memory. So we think it works through neuroplasticity, neurogenesis, synaptogenesis, some possibly with through the upregulation of BDNF. It definitely works on the default mode network, which we see with the other psychedelics as well, and one of the reasons why we think that they work so well to treat mental disorders. There's, in ketamine, a reduced connection between the medial prefrontal cortex and the rest of the default mode network. And that's been a hot topic in psychedelic medicine. And also there's a few other ideas that there's the disruption of reconsolidation of memory. Memory is also a really important thing that comes up in ketamine-assisted psychotherapy. It's why it actually really helps with PTSD. I've had patients who are brought right back to a traumatic memory, and it sort of plays out. And ketamine decreases fear, especially at some of the lower to moderate dose ranges. And then they can reconsolidate that memory attached to a different emotional experience. And so when that happens, that's really wonderful. And in the addiction literature, there's some thought that the maladaptive appetite memories in substance use disorders may be able to be affected by this mechanism. And then glutamate and ketamine, we see enhanced learning. So that's why when we pair it with psychotherapy, we get really good results. Because not only do you get the biological effects, but whatever you're learning, you learn better, you're more open to it, and it sticks. So besides the neurobiology, and this has been mentioned already, but the mystical experience becomes really important. And that's why we use ketamine through the dose range. The lower dose with the empathogenic effects and the decreased fear and defenses, but then up to the transformative dose where you become a point of consciousness and have a mystical experience. And this really changes people. And this is what changed people in the Krupitsky studies with alcohol, and this is what I see in my practice too for a whole range of different psychiatric diagnoses. So mystical experience is really important, and that plays out in the other substances too. So then, of course, it's really important to address the question, is ketamine addictive? And I can't say that even though I don't see it in my practice that it's not. Of course, it has addiction potential, and we see this through one of the famous ketamine users, John Lilly, who ended up injecting ketamine every 15 minutes and leading to a lot of psychosis. And so we learn lessons from that. So ketamine can be addictive, and we find actually in our practices, not with the troches that we send home or with the IM injections. I mean, many people wake up from the IM treatments, the more transformative treatments, and they say, I don't know why anyone could ever get addicted to this, because it really is very intense. There's a lot of a body load. They can't imagine doing it again. But done in small doses and done intranasally, we found, either with nasal spray or from snorting powder, that patients can become more readily addicted. So we don't prescribe it, even though even before the FDA approval of Spravato, there was ketamine that was available in nasal spray form. And we used it and experimented with it, and it's helpful for anxiety, at least in the beginning, but the abuse potential is quite high because then patients just keep spraying it to get rid of their anxiety, and there's really a decreased ability to modulate it. So these ketamine sessions that are sort of moderate or higher dose and done at frequencies of a few weeks to months, that's where we really see transformation. And then, as Rick was talking about, you don't have to continue that for the rest of your life. That really induces a state of change. And then if patients are motivated and working hard, and we're doing the other things that we do as therapists and psychopharmacologists and so forth, then, and just human beings, then patients get better, and they don't need to continue using the medicine. And that's a really appealing part of ketamine, and I think psychedelics in general, is that you don't have to take a medicine for the rest of your life and feel like you're just suppressing something. You can really move through it. So that's it. Thank you.
Thank you very much. Excellent. I should have mentioned at the beginning that the three of our panelists here all have papers in the journal that you have in front of you too, or co-authors. So now we will move to Dr. Alex Trope, and who's going to speak about psilocybin.
Hi there, yeah, I'm Alex. I'm a rising fourth year psychiatry resident here at UCSF, and I'm also a member of the Bonding and Attunement in Neuropsychiatric Disorders Lab, which is based out of the VA. And today I'll be discussing psychedelic-assisted group therapy, and especially its potential for harnessing this idea of setting, and substance. I have no disclosures, and I will be discussing psychedelics and and psilocybin in particular, which is a Schedule I drug with no current FDA-approved medical indication, though given what Rick presented, that might be changing. So I've been working with this metaphor to try to remember what the importance of setting substance, and just in listening to a few of the lectures I've added to it today. But I really think of pottery and the history of pottery as an important metaphor for understanding psychedelics. There's this river of life giving psychedelics that has run through history, and a lot of cultures and groups have attempted to carry that water to the groups and places that it's needed. I don't know if there's any archaeology or ancient history buffs, but pottery itself was a huge step forward for humankind. It allowed us to store things, it allowed us to create surpluses, which also allowed us to create waste, which allowed us to create inequalities, which from there it kind of expands. But the importance of having a vessel in which the psychedelic experience can take place can never be underestimated. And I really like this idea of the practitioners and researchers in these and policymakers in this room, kind of like potters patiently sitting and applying just the right forces to a piece of clay spinning on a wheel to be able to create something truly beautiful. And I think Rick and everyone else who's done that patient, diligent work. So probably a lot of people are familiar not only with psychedelics, but in a lot of psychiatry, set and setting is very important. Set is short for mindset and encompasses things like personality, preparation for an experience, expectations going into it, intentions. The setting, which of course could be the physical one, but also is the social and cultural environment in which experience takes place in both an immediate and a very extended sense going throughout history. And then lastly, the substance. I'll be talking about psychedelics, but any prescribers in the room probably know that someone's mindset and setting around a prescription for an antidepressant, around an opiate as a pain reliever, but also as a possibly addictive substance, plays a huge role in that. And then placebo, a sugar pill, which should physiologically only infinitesimally raise your blood sugar, it has all these profound effects based on set and setting, and that's been studied rigorously. So this creates the triple S kind of trifecta, and at the core of that, when you prescribe a psychedelic experience, that kind of goes along with that. And I realize I've been using my clicker here. Going back in history, the first potters of this experience were many indigenous groups and traditions that used peyote, mushrooms, and ayahuasca, both in ancient times and now modern. And what you'll see common to each of these pictures is a group. Now this was simultaneous group dosing, but it's also important to note that it was contained in a vessel of a culture, a religious and spiritual tradition. And that created this spiritual, entheogenic kind of model of psychedelics. Our model, the medical model, which many people are probably familiar in the room if you've seen any media around psychedelic-assisted psychotherapy, is this individual model where there's a single participant who receives therapy either from a single therapist, as in the case with what Dr. Dorr is doing, but also with co-therapy teams. And they are there to sit and help facilitate or support the experience. But just to name the obvious, even in this individual model, three's a crowd, and there's this sense that a psychedelic experience can be best held with a co-therapy team, as many of the teams in the MAP studies are being trained, oftentimes dual gender, which kind of expands the setting and set of the participant and the therapist, whose mindset is just as important going into any experience. So my team at our lab at the band lab was really interested in looking at the history of psychedelic-assisted group therapy, which was very common in the first wave, but changed throughout the Prohibition period, and has just at the beginning of a revival, even though there's been 10 years of these studies on individual psychedelic-assisted psychotherapy. And you have it available in the journal that you've all been graciously given. Our study was a systematic review of the history of psychedelic-assisted group therapy in a Western medical model. The definition we used of group therapy was pretty liberal. It was the use of a group element in the preparation, administration, or integration phases of psychedelic-assisted psychotherapy. Our criteria for inclusion was that, and these were often studies from the 50s and 60s before the IRB era, the era of kind of rigorous research standards, was that at least it be in a clinical rather than healthy subjects or forensic population, there would be some description of group methods involved, that demographic and diagnostic information would be available, and that there was some quantified outcome data as well. Going forward. All right, here's our study selection. So culling down from major medical databases as well as psychedelic-specific bibliographies, we ultimately had 500 sources that we analyzed and reviewed, and found 12 studies that met our research criteria. Of those, the most common psychedelic, rather than psilocybin, was LSD, which was available at that time, pharmaceutical grade. Typical doses ranging over a large dose range, just as with ketamine. And of the 12 studies, there were roughly 700 participants in total that received a psychedelic in a psychedelic-assisted group therapy model. We created kind of two buckets for the resulting studies. The first was in the treatment of alcohol, which was kind of the forebearer of the psychedelic-assisted psychotherapy model, and where a lot of our research on the importance of set and setting first occurred. All 5 of these studies occurred in inpatient alcohol treatment programs. 3 of them used a group component just in the preparation and or integration phase, while 2 of them utilized simultaneous group dosing protocols. And important to note that 4 of the 5 controlled studies of these 12 overall studies that were identified by the review occurred in this alcohol treatment population. And to zoom in onto these 4 controlled studies a little bit more, it was basically a draw between 2 that reported very promising improvements in measures of sobriety and social functioning, and 2 that reported null findings. Drilling down into that, I think it really shows the importance of the setting substance trifecta. So the 2 that reported improvements either used a 12-step AA model that was specifically adapted for psychedelic administration, or some other group therapy manual that had been very closely adapted for the needs of a psychedelic user, both in the acute administration phase and before and after. And they typically used LSD doses ranging between about 100 and 400 micrograms, never above that, which is, you know, moderate to high moderate doses. Whereas the 2 that reported null findings lacked psychedelic adapted group models whatsoever, and used doses oftentimes much higher than the 400 microgram level, up to 1,000, which could be an overwhelming experience for even a very, very seasoned user. So just to show you one of those that I'm surprised got null findings instead of negative, therapeutically negative findings, specifically gave high doses, 800 micrograms of LSD, and during the individual drug sessions, placed patients into a bed and physically restrained them with a posy belt over their lap or chest for the duration of the peak drug effect. And then during post-drug therapy sessions, which they were called, there was no, quote, no special effort to examine the results of the drug session unless the patient requested it. So this was surprising that there was actually just a draw between the placebo arm and the high-dose LSD treatment arm, because I would expect that could have created a lot of nocebo and negative effects. And the reason that the 2 studies that found improvements likely had those is they were connected with this research team, which often called the Saskatchewan team, based out of Saskatchewan province in Canada. It did amazing work in the 50s, 60s, headed up by this gentleman on the right, Humphrey Osmond, who is seen here with his 2 collaborators, Abram Hoffer and Duncan Blewett, observing a traditional peyote ceremony when they were just becoming familiar with these substances, and then talking with a variety of users, famously Al Hubbard, known as Captain Trips, who kind of like Leo Zeff for MDMA, gave thousands of doses to people and really cued into the importance of set and setting, and started this whole thing rolling. And then Duncan and another collaborator, Dr. Chuelos, created the first handbook for therapeutic use of a psychedelic, and they included both individual and group procedures for doing so, and this was reproduced by MAPS and really is the harbinger for the modern day psychedelic manuals that are being created. The second bucket of psychedelic assisted group therapy studies we found were in the treatment of neurotics, and we found 7 studies overall. Neuroses in the 50s and 60s was a large diagnostic heterogeneous category. Today it would mostly equate with affective mood disorders, anxiety disorders, personality disorders. And there was also a heterogeneous array of settings in which psychedelics were given. So 2 inpatient psychiatric wards, 4 outpatient settings, and one partial hospitalization program, actually a night hospital in which patients stayed the evening and night and then went out during the day to either work or other activities. As opposed to the previous bucket of alcoholic studies, 6 out of 7 used simultaneous group dosing procedures, and 3 used LSD in combination or in sequence with a stimulant like Ritalin or MDMA. And all the uncontrolled studies reported clinical improvements. There's not much to say about that causally, but at least it showed some safety and feasibility of doing this, even with group dosing with people with a variety of diagnoses. The one controlled study, which was unorthodox but a valiant effort in trying to control for certain aspects of this, had a course of group therapy in which roughly 40 people were involved. And then they split it into 3 arms. And for a single one of those group therapy sessions, about 10 participants received a light or psycholytic dose of LSD, 50 micrograms IV, as well as a saline control of another 10 or 15 individuals. And then also present in that pretty large group, which would have been fun to be a part of, I think it probably was pretty unwieldy, there had been what they call LSD-X patients who had already received an individual dosing session at 100 micrograms, kind of a standard dose. And what's most interesting about this study is they did, in both the immediate follow-up, it was these X patients who'd already received individual LSD, whose reductions in various measures of neuroticism was largest. And there were still reductions in the placebo and group arm, but there was no significant differences in between those 2 arms in terms of their benefit. And then at a 1-year follow-up, those who had received the course of therapy with this individual sessions had the most durable and long-lasting effects, and they were actually the only durable effects at 1 year in terms of improvement in symptom burden, in social functioning. So it gives you a kind of idea of how this close, personalized attention in an LSD-assisted individual psychotherapy session extended into almost like a familial group in an inpatient ward might be of most benefit. And it was this that interested our band lab the most, because we were in the process of undertaking the first group therapy-based study with a psychedelic of the modern era, which we call the PASS study, which is psilocybin-assisted group therapy for demoralization in long-term AIDS survivors. Long-term AIDS survivors are individuals who received their HIV diagnosis in 1996 or before. And we wanted to see how we could take psilocybin-assisted psychotherapy, which has already shown a lot of promise in treatment-resistant depression, in end-of-life anxiety, and apply it to a population that's especially important to the heart of this city, which is HIV/AIDS survivors. And we've already run 18 participants as part of 3 groups. They've been all male groups, kind of affiliation groups that have a lot in common already. One of those things being this quality of demoralization, which is pretty rampant, which is this syndrome of feeling poor coping in the context of a sense of hopelessness, helplessness, and a loss of meaning, purpose, and social connections in life. Engel in 1967 called it the giving up, given up complex, and is well known to a lot of people facing life-threatening illness and having experience with that. The study is as follows. This is our study design. So I just wanted to highlight, give you some pictures both of our group therapy room and our individual sessions treatment room. As I said, we've run 3 cohorts of 6 participants with 2 co-therapists each. They come in for enrollment. They do some individual therapy with the co-therapist just to get to know each other and make sure that the group will run well. They have 2 weeks of intensive group therapy, including all the necessary preparation, the set part of our procedure during that time with 5 other peers who really understand their experience of trauma and complicated grief from the HIV/AIDS epidemic. The most striking figure for me with this population is that some of our participants have gone to upwards of 100 funerals in just the span of a decade. And then they have their individual psilocybin treatment session, which follows the protocol laid out by a lot of other groups at Johns Hopkins, NYU, other places. And they come back together after a week off in which they're all receiving the psilocybin individually to integrate that as a group. Our study, group study manual is based off supportive expressive group therapy, which developed by David Spiegel and others at Stanford for especially prominently breast cancer patients. And in total, they receive about 15 hours in the group and an additional 3 to 4 hours of individual psychotherapy plus the day-long session. And I just want to show some initial primary outcomes. So In terms of demoralization, that complex, that's not a DSM diagnosis, but very important in the palliative and medical field, we've shown large reductions that take place. This is not a controlled study, so we can't causally say what's occurring, but you can see between week 2 and week 4 or 5 when the psilocybin session occurs, there's this very large reduction in demoralization. A Hedges G, which is an effect size of 0.99, is as close as you can get to 1, which is kind of the maximum score there, and it's highly statistically significant at less than 0.001. We also looked at corresponding measures, kind of secondary outcomes, PTSD, which is interesting since PTSD is associated kind of with MDMA right now, but we are finding some very therapeutic responses in patients, only a few who actually met PTSD criteria, but PTSD symptomology, and then also in depression, similarly, these moderate to large effect sizes over the course of that. So what are the next steps? I'm in charge, this is headed up by Brian Anderson, who Rick Doblin already discussed, as well as several other co-PIs, I'll think, at the end. I'm in charge of doing a study on the kind of group process, which Rick was mentioning therapeutic alliance, the kind of analogy of therapeutic alliance between a provider and a patient in a group setting is group cohesion. So I'd really like to look at that and other group process measures through linguistic and conversational analysis of the groups, which we have transcripts for and video of. The picture behind this is actually a 360 video that we would take of the patients in the room. And then I'd love to see some correlations between that and self-report measures on group cohesion and social connectedness that we obtain from the participants. We are recruiting, beginning to recruit for our 4th cohort of the study, which will be an all-female participant group. We had originally just been recruiting men and trying to keep single-sex groups, but we heard a large outcry from women with in the long-term AIDS survivors group, and we're glad that we found the funding to provide at least a small sample for that. And then Rick already mentioned that from what we've learned here, we're really interested in applying it to the most social or the most trust-giving kind of substance that we have in the emporium, which is MDMA. And so this idea of integrating it for PTSD, of seeing both whether it has parity with individual psychotherapy or if there's actually some aspects of it that are particularly beneficial. I would think that any aspect of a disease that causes social isolation, an antidote to that is coming in to a group, and you can create kind of lessons and draw that water from the psychedelic river and carry it a little bit better in a container with a group and extend it out into your life and new lessons and habits through a group pretty powerfully. So with that, I just want to thank all my collaborators at the Band Lab and others. As you said, Brian Anderson has been a great mentor. Alicia Danforth and Rob Daroff were also co-therapists in the group. Philip Pearl, who's in the audience, is our study coordinator. Chris Stouffer and Josh Woolley, who are PIs at the Band Lab, and Jenny Mitchell, who's helping to run the associated MDMA phase 3 trial at UCSF. And then it takes a village, especially when you don't necessarily have the highest government support. Thank to everyone. Thank you to David and Steve and everyone who organized this panel. It's been really great.
Okay, so a lot of talk about MDMA, and our next panelist is Dr. Jerry Beck. He is actually co-author with Marshall Rosenbaum of a book called Pursuit of Ecstasy, the MDMA Experience. It was the first big study of the use of this. It came out 25 years ago this year. So, Dr. Beck.
First thing I wanted to do is look at the time, so I want to make sure that Marsha has a chance to comment on this, and we have plenty of time for question and answer. So I will go to 11:40. Okay. What I want to talk about today is a couple of different studies. Steve put up the Exploring Ecstasy study. These are both qualitative studies. This was the first sociological study funded by the federal government. We got it just after MDMA had become illegal, submitted it in 1986, and the study took place from 1987 to 1989. And then I'll conclude with a much, much more recent study, the therapeutic study, which was essentially the first qualitative study with MDMA for therapeutic purposes with the Mithofer's veteran sample in South Carolina at their one-year follow-up. So just real briefly, I just want to, because a lot of this is kind of a shout out to David Smith and the Haight-Ashbury Free Medical Clinics and the Journal of Psychoactive Drugs and their influence on kind of shaping my interest and career. Growing up in Eastern Oregon, Idaho border, the one drug beyond marijuana that we had plenty of was a lot of LSD. And there I encountered experiences, including a negative experience, which I attributed solely to strychnine because that was part of our folklore. And I came to the University of Oregon very interested in the study of substances, particularly in looking at drug set and setting, the idea of user folklore and knowledge, expectations, beliefs, and particularly how they shaped drug experiences, and in particular psychedelic experiences, of which I had a particular interest. I immediately went to our library. We had the whole set of the Journal of Psychedelic Drugs at that time. This was in the mid-70s to early 80s. And I was just fascinated with the incredible epidemiological exploration that took place in there through a number of both Dr. Smith and Dr. Wesson, this famous Smith and Wesson team, George Gay, Skip Gay, and later on others, Daryl Nava, John Neumeier, who did amazing epidemiological work on the whole San Francisco Bay Area, which Dr. Aragon is continuing. And others that I'm forgetting at the moment, but were really critical in kind of shaping my understanding of how to approach and look at substances and the study of them. Also came down to Berkeley to get residency for grad school. I worked at Chinatown Youth Center, where I worked with Dr. Inaba a lot during the early 80s. And then at Berkeley, I was interested in studying both drug education and drug epidemiology, and with a particular interest in qualitative research. And I was fortunate enough to get an internship with Marcia Rosenbaum on a methadone study. And later on, we submitted the grant. She was the principal investigator of a study, the Exploring Ecstasy study, which I briefly talked about before. And in that study, what we tried to do is, in submitting it to NIDA, was not interested in the therapeutic potential in any way. We looked at a bunch of different user groups in which we did include a lot of therapists and a lot of interviews, and some people who happen to be here. Also, Rick had mentioned Debbie Harlow, who is pivotal in the formation of Rick's organization. She was one of our co-researchers, and I think we were able to access a large population and do extensive qualitative interviews and be able to get a good sense of not just therapeutic populations, but use among the gay populations, among New Age, as we refer to them, New Age seekers, even a Grateful Dead contingent at that time. And essentially, we culminated in publication in both in the final report in 1989 and then in our Pursuit of Ecstasy in 1994. My dissertation at Berkeley was 1990. More recently, I've been involved with the therapeutic research with MDMA. And it was 2013, so about 6 years ago, I managed to convince Rick and a generous funder to finance an initial pilot study of, in this case, the Mithofer's Veterans Group. Unfortunately, the study had already begun, so we're kind of going in midstream, and we're trying to figure out, in terms of this kind of exploratory qualitative research, how best to do it. And we decided on the one-year follow-up to do interviews with the veterans at that time, since many of them were already starting to go through that process. Fortunately, a couple had done their one-year follow-ups. Out of a total of 24, we ended up getting 19 interviews. Because these were in South Carolina and limited budget, we couldn't do the interviews, so we had was up to Andy Mithofer to do those. And that was a decision that it was a practical one. Ideally, you would have a situation where you would have somewhat of an independent research team. Oftentimes, any graduate students in the particular area that were doing therapeutic research would be ideal. And I think a good instrument in terms of that, what we went for with the one-year follow-up was the long-term follow-up questionnaire, which I spent the first year helping to revise for MAPS. This is something that they use in all of their follow-ups. And they were in the process of revising that. Kind of how I got Rick interested in the first place is that in 2013, the Mithofers had published the 3.5-year follow-up of their first cohort, which were women who were rape and incest victims. And at 3.5-year follow-up, they gave them the long-term follow-up questionnaire. And in that questionnaire, mostly you're answering yes, no, rated on a scale of 1 to 5, and things like that. But there were some spaces where if you wanted to add some additional comments, feel free to. And what they found, and they reported in their piece in Psychopharmacology, is that almost all of the individuals, subjects in that study, did have a lot to say. Even in the small spaces that they were provided, they would go into the back of the sheet and provided a lot of commentary. And so in that 2013 3.5-year follow-up, the Mithofers, Rick, and other public authors kind of listed some of these additional comments, but were kind of forced to say this is anecdotal data because not everyone submitted it. It was just kind of a blank space. But it seems useful that we start to collect some type of information. And that's the genesis of why we started to do the qualitative. It makes sense that you would do qualitative research when you're investigating an insight-enhancing substances such as MDMA, psilocybin, any of the psychedelics. And in fact, the first efforts were done at NYU, and there's a number of great publications of qualitative research done with sufferers of terminal illness there. That kind of helped inspire us, helped us with our methodology in picking out IPA as the methodological procedure that we would follow. And I would say that, sorry about this, I guess I would, let me see, I said 1240. I would just like to conclude that with two things. That there's a number of different projects that I've been learning about that are going on now with qualitative, both with psilocybin, with MDMA. I think the paper that you have that's in the journal that you received represents a good fundamental first exploration of this population, but I think some of the challenges that we've encountered, we're now able to go past that and come up with better strategies to help get the whole population to figure out the situation of when to interview, how often, and who to do it. And I would just like to conclude that I'm glad that Philip's here. Pearl is one of my co-authors who's now working with the psilocybin study. And Will Barone is the lead author, and he's one of the people that is kind of leading the way in terms of new qualitative research, and I'll quit there.
Thank you for that. So we had Dr. James Fadiman scheduled to be here today. He is not feeling up to coming over to here today. He is, of course, the guru of microdosing, which I'm just going to say how many people have heard of it. How many haven't heard of microdosing? Okay, so he has a paper in the journal. He sent me a newer, updated one with some more information and just a couple of remarks about it. And I think it's a fascinating concept. I kind of consider it the homeopathic psychedelic realm. So the science of it is extremely fuzzy at this point. The regimen that he puts forth, to me, makes no scientific sense, but then anecdotally, many people find that this is something that's very useful for them in some ways. One of the ironies, of course, is that it has become adopted a lot in the tech world, et cetera, as a productivity tool, which is kind of the opposite of tune in, turn in, drop out, right? This is about working better. So he does say in the newer edition of the paper that he sent me that he is starting to see the kind of research, the double-blind studies, et cetera, that are needed to talk about how this might work. I mean, it's really talking about, say, 10 micrograms. If you're talking about LSD, 10 mics of that, which, in the 60s, people were doing more like 250, 300. More recent years, it's been down 100, something like that. So a fraction dose. And a lot of it considered to be subclinical, but in some way transformative. So in any event, maybe we can post his new paper on the website after you look at that, but there is one in the journal. And we hope he feels better soon, too. So I asked Dr. Marcia Rosenbaum, an old friend and colleague, to comment on what was heard here today, briefly, but also because of, as mentioned earlier, her drug education program is becoming the state of the art. It's being rolled out in a very big way in public schools after, again, a long struggle, you could call it, to get accepted more of a harm reduction approach to drug education. So, Marcia, please come up.
So you've heard a lot about research, about ketamine research from Jennifer, about group therapy from Alex, and MDMA treatment, assisted treatment, then and now from Jerry Beck. And Jim Fadiman has talked about microdosing, which you didn't hear about, but you can read about later. So in all of this, I always come back to the question, what about the kids? What about the kids? Rick, what about the kids in all of this? And I do it because I've been looking at children, and I have children, and frankly, I'm concerned about the kids, as I know you all are. So there's a little saying that's kind of new, and that is, education is the new prevention. So what I've been doing for a really long time, 23 years really, is looking at drug education and how effective it is and what we can do to make it better. So after all of this time, 2 decades, we at the Drug Policy Alliance have created a curriculum for high schools, a drug education curriculum, which you can read about in this booklet. And what it is, it's called Safety First, Real Drug Education for Teens. And in this curriculum, we have 15 lessons. It's got a harm reduction focus, but we have lessons about stimulants, marijuana, cigarettes, vaping, which is the new thing, prescription drugs, opioids, and others. Number 10 in these lessons is psychedelics, which I have to tell you 2 things that I've heard as I'm observing this curriculum being delivered in San Francisco here. And the teacher asked the question, have you heard of psychedelics? And one kid raises his hand, he says, you mean psychedelics? In other words, psychos who use these substances. Another question from the teacher was, who do you think uses psychedelics? First thing I heard, I could barely contain myself from really laughing, old hippies. Yes, I know them. And so the question in the psychedelics lesson, we talk about the risks and we talk about the benefits of psychedelics. Because if you skip the part about the benefits, nobody can understand why anyone would take these substances or any other substance for that matter. So you've got to include the benefits, which we do. We go through a list of the most popular psychedelic drugs, and we do include MDMA in that. I was surprised that most of the kids, they'd heard of LSD, some had heard of psilocybin, none had heard of ketamine, but MDMA, they didn't quite know what that was. They didn't even know what ecstasy was. What they did know, though, they knew about Molly. That's the new name. And so, and a lot of what they've heard comes to them in music and in the media. And so part of our lesson is teaching teenagers how to be critical of what they hear and what they read, how to be critical thinkers, and how to learn for themselves, how to do their own research, which is so easy these days, using the internet. But we also teach them, using the internet, be critical of the site you're using. If it's too good, if there's no problems, if it's all good there, move on. Or if it's terrible, it'll kill you, you move on from that too. So media critique, but also my favorite part of this lesson, the psychedelics lesson, is that we teach about, and we actually reference Norman Zinberg, drug, set, and setting. Because with psychedelics, there is nothing more important than the drug, the set, headspace, and the setting. So that's what we do. That's our curriculum. And I wanted to leave plenty of time for you to participate and ask questions. And that's it. I think they want you to come up here.
Yeah. Rick, you want to come up here too, please? Thank you. While he's coming, one thing I like to do with the panel always is, do you have comments or questions for each other on what you've heard today, briefly? Anything strike you as shocking or scary or beautiful or anything like that?
I just thought it was interesting to the mention of long-term follow-up. And Rick, you mentioned people getting even better and possibly opening the space where they can do their own work in their own family and social settings. And then you were speaking about trying to get that actual data. So I just find the interest in where either convergence or divergence between the different substances and modality occurs 1 year out of the study, 2 years, 5 years, pretty interesting, and how we might actually be able to grasp that and get some data on that would be interesting. And you were kind of getting into that, the difficulties of trying to convince people once you've shown the big fireworks of the self-report scales and other things, how to get some of that more rich qualitative data and how you might experience it in the community.
I think that definitely, this is where I'm particularly interested, is in the long-term, like with that first cohort of the Midhofers is now probably 8 years, 9 years on average since their last MDMA session. I think that it would be incredibly invaluable to do both. There's the long-term follow-up questionnaire, which is much more quantitative, that they fill out, followed by a qualitative interview, I think would be amazing. And I know that the subjects are really motivated to speak about their experiences. One thing I've noticed from the second cohort, the veterans cohort, is at least a third of them have come out publicly in media, different articles, to speak about their experience because they felt kind of so motivated to do so. It's incredibly changed them, and almost none of them would have ever thought of doing that, when they were before their experience.
Yeah, we should work together on this because we're actually doing a long-term follow-up to everybody that was in phase 2. And we're primarily doing it for insurance company to look at healthcare utilizations, to try to see if we've reduced their need for medicalization or emergency room visits, all of that. But we could add more qualitative stuff to that.
Hello. So I don't have the data or the quantitative things to speak about, but when I started using ketamine in my private practice, that was 5 years ago. So I have a lot of anecdotes and vignettes about patients who have been transformed by using ketamine even just once. I have several patients who used it once, and they had relief from their symptoms of depression, and they hadn't needed any follow-up with ketamine. So it'd be great to also get that together. I know that Phil Wolfson has clients that have been 8 years out. So pulling those things together, I think that we have sort of a similar picture of medicines that are really changing people.
Alex, I had a question for you. So for the MDMA group study, we're talking about it with cognitive processing therapy. So did you do any of that kind of work with the psilocybin groups? Or?
I'm not trained in cognitive processing. The little I know of, it's very manualized, and you have a few aspects of both talk therapy and written stuff. What I found most interesting is that we had taken measures of trauma in this population and knew it was high, and that there were some real outliers in our group. And I think there is some correlation with the kind of difficult experiences they had on the day of with that. But what was most interesting is I was involved in one session in which, because we had to get 6 participants through a day-long session in 1 week, so there wasn't too much of a lapse in time between the preparation sessions and integration sessions, we had to do 2 people at the same time in a pretty small lab. So there were 2 rooms being run at the same time with 2 co-therapists in each. And in one of the days that I was sitting as a co-therapist, my participant was having unity, mystical experience, like blast off, just very powerful experience with hardly any difficult transition point. And in the room next door, there was someone having a very difficult experience. And at the end of the day, the 2 participants, if they feel up to it, get to see each other and spend an hour kind of beginning, we tell them not to try to delve too deep into the material, but just to see that support, and we didn't know how it would react if someone else comes in, happy as can be, and you've just gone through something very difficult, and this person was processing very directly the trauma of having been a nurse on HIV/AIDS wards at the General in the 80s and 90s. But the two of them created this spark in that moment that was really important. And so I'm not sure if that would actually latch on to any idea of cognitive processing. But I do know that to feel less alone in something is a huge part of what trauma creates. The avoidance cycle is the thing that really adds fuel to the fire of it. So I think that the idea of taking a group, cognitive processing, and then having solidarity amongst a variety of experiences in the room, because that's important to know that people don't feel then cast out because they didn't have this unity experience, which is kind of an expectation that is set now, because we always show those articles, and Michael Pollan writes about his own experiences. But if he had just had his 5-MeO-DMT experience, what he said, where he just like fragmented and couldn't get himself back together, I think it would be a different story. And you really need to you need to be able to tolerate difference, which is a key factor in group therapy. And different experiences allow people to feel more a sense that they're holding more of the world.
In Michael Pollan's book, he summarizes very briefly the discussion of addiction, since this is our conference here, by saying for psychedelics as a whole, it's the evidence and the promise is modest but very encouraging, quote unquote. Would you reflect on that at all? Do you agree? Do you think that's true in your own experience? Anybody?
Just want to make a remark about addiction and psychedelics. I don't know, 30 years ago when we first started the MDMA study, Debbie Harlow, who's here and really should get a lot of credit for so much, so to you, Debbie. I asked her about addiction. I said, well, wait a minute. What about it? This feels so good. Why wouldn't people use it over and over and over again? She says, you know, Marcia, you only have 10 good trips. To which I said, what? You're kidding. But that's what we tell kids in the curriculum. The more you do, the less it works.
Let me speak to that also, because one thing that we did do in the Exploring Ecstasy study in one group that I really tried to oversample were people that we knew, that I knew, other people knew, that were already stimulant enthusiasts, let's put it, with cocaine, methamphetamine, and to see how they processed MDMA, how did that fit into the picture of what, they had a tendency to overuse. And sure enough, many of them did try to overuse MDMA, but there seems to be a built-in anti-abuse mechanism for at least most people, such that for some people, they didn't go back to their former stimulant, or they wouldn't go onward with MDMA. They would go back to they would go back to cocaine or to methamphetamine. And this is something we've also seen in the rave scene overseas, and as well as here, is the tendency to want to do MDMA if you're going to dervish dancing all night for a weekend, to keep doing it and add doses, stack doses. And that's something I've always been interested in, is there's always the tendency to for methamphetamine to enter that scene, or to other substances for coming down. And so trying to fit it into kind of the stimulant depressant cycle is important to keep abreast of.
I have to say that, in the context of ketamine and even all the medicines that I've given in my practice, and even educating people on alcohol and cannabis before I even used ketamine, with patients, is what's your intention? I think that if you keep the intention of what you're doing, anything what you're doing, whether you're using the internet or you're, eating food, is that if you're doing things with intention, you very rarely go wrong, and you're very rarely, doing things in an addictive way. So that if you understand and have awareness, and I think that's why when psychedelics are a medicine in the context of culture and religion, and how I think that we're trying to use them here, that there's just a lot of there's like less chance for error, because going out, I don't know if you have just 10 good trips. I think it's too simplistic. I think that you are able to enhance the growth and transformation at whatever point you're at, and if you're continuing to work on that level on yourself, on your own self-awareness, on bringing more awareness and intentionality to everything that you do, not just using medicines, then you'll get breakthroughs at different points when you need them and when it fits in. And so you'll have a good trip, and sometimes actually a good trip is not the best trip for transformation. And with ketamine, and this is the way we work with it too, is that some of the times when you get agitated or face difficult things can be the best teachers. And so I think it's the way you look at it versus like using a substance to change the way you feel. And educating patients in the difference of that is so important, whether you're giving them benzodiazepines or, antidepressants, or, what is it doing to you, patient education, them understanding, and them understanding their own motivations. I think that's really, really important. And then I think you see decreased addiction. And then you can spot it and bring it awareness to people when they're not doing things with intention. But if you start with that, I think you have a better result.
The famous comment from Dr. Richard Alpert, who of course was Timothy Leary's partner in the early experiments at Harvard, and then he became Baba Ram Das, and his statement was about the use, once you get the message, hang up the phone. Right, so there is an end point there.
Let me just comment on
yes.
that. Where I think that there's a lot of different messages that you keep getting. So I think that's not a really good metaphor.
This has been fantastic. Thank you, all of you.
Steve, I want to ask.
Yeah, Marsha.
Mostly Alex. So I have found one of the benefits and pitfalls of MDMA, which is the one I know the best, in groups, dyads, couples. One pitfall, and I don't know how this, bites you in the end, is the urge to be truthful. The feeling that it's all safe and it's all good. The urge to do true confessions. I found that can be, that'll bite you later, depending on what you say, because ultimately, you come down. You go, what did you say? Really? That's what you did? Anyway, had to.
That's about setting. Yeah. And setting. Well, you're right. I mean, I remember in the peak of the rave here, there were a lot of people seen at the hate clinic who had been harmed in some ways, whether it was sexual abuse or whatever, where they felt something. It was a beautiful thing at the time, but was not. So.
I'll let Alex answer because you asked him, but I'll just say that it's about the integration process. So when you come out with things that are very truthful, it takes a while sometimes to deal with them afterwards. But that's the role of the psychotherapy, to help people really to acknowledge it, own it, and then what are the implications of that. And so one of the things that we do tell people is, don't make any changes for a significant period of time after the MDMA. Don't get married for 6 weeks until after you do, at least wait 6 weeks before you get married, yeah. So I think it's really, again, this, you do say things. There was one of our Israeli subjects that, under the influence of MDMA, acknowledged that he had committed war crimes. And that was very difficult for him he sort of suppressed it for 19 years. And that just takes and that was very hard for him. So he had a lot of hard time integrating that in the weeks, but that's where the therapy really comes in.
Yeah, I think what's important and one of the detriments of psychedelics use could be ego inflation or ego boundary kind of loss. And that's why someone asked me last night, why do you think group therapy with psychedelics kind of hasn't made the same resurgence that the individual psychotherapy, and that's because it got associated with cults and other things. And people use this as a kind of neutral term, but did call it cultogenic, in the sense that people having a psychedelic experience will seek out find the ones, or whatever Timothy Leary said, find the others. And I don't think that's a negative, right? One of the reasons we're doing group therapy is that there's now a lot of community psychedelic harm reduction and support groups, which are very important. There's a lot of participants in the individual trials have asked to be connected and have been connected with other participants after they complete the trials, and found that to be really beneficial in keeping the kind of meaning of the experience, having the validation of non-ordinary states of consciousness. So I think MDMA, right, which doesn't necessarily give you this abrupt sense of a transition from self to other or self to universe, has, the preparation has to be about healthy ego boundary, and the kind of confession as not necessarily the necessary thing at all times. That's anyone who's worked with someone with insecure or disorganized attachment knows that confession can be readily available to those people, and yet the most therapeutic thing would be to walk that back and have them actually be able to contain things and in a healthy kind of experience with the therapist first, and then maybe eventually with a peer participant in group therapy, and then maybe eventually with just someone you're meeting off the street. And creating that continuum is like a very important part of the integration process, which takes a lifetime. So.
And I think it can help you to address something that's really important, which is pendulating between being able to be vulnerable and being able to have healthy ego boundaries and work within the society which you are, which we're trying to do with psychedelics, and being able to experience those two states. And I think that's also why it's important that the medicines are in the setting of education and in the hands of people who are trying to understand them, and from 360 degrees, because otherwise something like that can happen. And preparing our patients for it, and then like Rick said, and we're all saying, the integration process is key. So recommending that someone do a psychedelic without those components, which some people come in and ask me for ketamine, I just want to come in and I want the medicine, and I'm like, that's not the treatment, and that's actually reckless and has the high potential to do harm, more than anything else.
Okay. I've been asked to do this by a few of our faculty members, and I started with the poll. So this won't be a double blind, it's going to be single blind, because I'm keeping my eyes open, but everybody else in the entire room, please shut your eyes for a moment. And you don't have to answer this, but I'm the only one watching, unless somebody's cheating. No cheaters. How many of you, by your own definition, have ever had a psychedelic experience that you felt was beneficial to yourself? How about one that you felt was negative? How about both? Okay. It's a large number. I would say half here, almost 40 to 50%, said they had a positive one, a lot less a negative one, and same number of both. So it's very interesting. I just wanted to know that. I think the panel was unanimous one way or another. So, you can open your eyes now, yeah.